Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Knee.
Hello class. I've got Kristen on the table today, and the focus of this lesson will be a knee exam. And I'm actually going to demonstrate a patella as well as the normal knee procedure consisting of an AP and a lateral. Of course, some of your institutions, the patella might be a normal part of the protocol. You do AP, you do lateral, and you do the patella. And some places even do an oblique. But the main three that we're going to show you in this lesson is the AP, the lateral, and a patella. I have the patient lying on the table. Her body is straight, and she would be in a gown, or her pants would be raised up. Somehow you would have the knee free of clothing. And we have a 10 by 12 in the Bucky tray, lengthwise, the IDs to the top. And I've prepared an arm marker close to the setup. Before we actually go to position the patient, I want you just to look at her body habitus for a second, just kind of focus. And you need to analyze the femur and look how it's fairly parallel to the table. And I also need to explain that you're going to be working with technologists who've been trained in previous years with previous editions of the Ballinger textbook in positioning. It's just the recent editions that are talking about a variance in the tube angle for the AP. So that's why I wanted you to look at her leg for a second. She's not a very heavy patient by any means. She's very thin. Her femur tends to be parallel. Some patients, the femur might end up being a little angled this way. If the femur is angled this way, or the patient is small, the Ballinger text encourages you to angle the tube caudally 5 degrees. I consider Kristen to be fairly normal, maybe a little on the thin side, so I'm going to leave the tube perpendicular, or I might elect to put a caudal tube angle on there of a few degrees. If Kristen was heavier, her femur would, picture adipose tissue here building the femur up, and the femur would be at an angle like this. If the femur's at an angle coming up, you should have a 5 to 7 degrees cephalic tube angle. Again, a cephalic tube angle, because you're wanting to come in perpendicular to that joint space. Okay? You're going to have to analyze the patient's leg, and you will have 3 options. A caudal tube angle of 5 to 7 degrees, or the tube may be perpendicular, or you may be angling cephalic 5 to 7 degrees. And I hope I've explained this well. If the femur is parallel or angled a little bit this way, it would be a caudal tube angle. Perpendicular beam and a cephalic tube angle. So let's do our demonstration now. I have 10 by 12 collimation, and again I mentioned we have the cassette. Once the tube and the film are lined up in a floating tabletop unit, once you have things lined up here, you can push the cassette in and then just float the table to where you need it. The femur is straight, and I'm going to put this crosshair down the center of her leg. Okay? And then the patella, the soft tissue here, you do not palpate a patient's knee when it's hurt. I'm gently touching her knee now, and right there is the apex of the patella, right there. Some students think that the apex of the patella is at the very base of the dip of the soft tissue hill here. They think it's right there. That is not the case. I'm going to push on this patient. This is mocking for demonstrations. Do not do this with a real patient. But right there, I'm moving that patella up and down. Actually, relax your leg and feel for the apex of your patella and feel how it moves. This would be the base of the patella, the broad part. This is the apex or the point. And the vertical crosshair will enter 1/2 inch below the apex of the patella. That's where the actual knee joint is. 1/2 inch below the apex of the patella. to the center of the film. Now we're going to roll the leg in just a little ways. Don't need to on you. The camera has realigned itself so you'll have a better look at the leg this way, because what I'm trying to show you, if the leg is in a true AP position, the patella will lie slightly medial. It's not in the center of the leg, it's slightly off center of the leg towards the medial side. So you're going to look at the edges of the patella and you're evaluating the space from the edge of the patella to the side of the leg, edge of the patella to the side of the leg. Kristen actually has her leg too medial now. Let me outline the patella for you. See how my fingers are really shifted to the inside of her leg? It's not just slightly off of midline, it's way to the center of the leg. So we're going to bring her leg back a little bit, and now see how we're just going off of midline just a little bit. That's what you do. Let's take you more lateral, Kristen, so they can see. See that? That would be to the lateral aspect. You don't want that. You want the patella not midline, but slightly medial. That will actually place the condyles parallel to the surface of the table here. Okay? We have crosshair coming down the center of the leg. The leg is turned in just a little bit to have the patella to the center, or excuse me, have the patella slightly medial. And then this crosshair here enters the leg 1/2 inch below the apex of the patella. Collimation is 12 inches this way. Keep that 12. This way you open the collimation up no larger than 10 by 12, but Kristen's leg is slender. We're going to bring that collimated field in close to the soft tissue, particularly if you are phototiming. And then the R marker is going to go to the corner just outside of her soft tissue. It's into the shadow of her pant leg here, which is okay. You just don't want it into soft tissue. And this would be an AP knee. Now, if you are angling the tube, either caudal or cephalic, we're going to put a 5-degree cephalic tube angle on there. Notice how I didn't move her, didn't move the tube, I only put an angle on, and see how it's entering high? That's because we've taken a perpendicular beam and now we're angling cephalic. I'm going to have to readjust the tube. Here's the apex of the patella, and normally you would enter 1/2 inch below that. Well, when you have a tube angle, instead of a 1/2 inch below that, you might be, say, 3/4 inch. You have to shift your entrance point just a little bit, so when it goes to the center of the leg, you're actually at the true point of the joint. So I'm a little bit more than 1/2 inch below, and then you make sure that you're exiting right back to the center of your film. And if you were angling caudal, instead of being a 1/2 inch below, remember you're shooting that way. So instead of being a 1/2 inch below, you might be, say, 1/4 inch below. You have to critically think that through. If you do put a tube angle on there, remember you should actually adjust your SID 1 inch for every 5 degree of tube angle. So I think I've discussed different scenarios that you might face with the AP knee. I reviewed to you the centering portions. On a radiograph, if you evaluate your effectiveness, the tibial plateau and the intercondyloid eminences should be cleared from the femur, and the patella should be lying slightly medial in evaluating your film. Tight collimation because of the automatic exposure control. Without tight collimation, the cell is going to pick up density from the tabletop and terminate your exposure earlier, and you'll end up with a light density radiograph. That was the AP knee. We're going to change cassettes. Same 10 by 12 ID to the top. I'm going to want to keep my R marker where I had it before to a lateral corner. With the AP, your choices again were this corner or this corner because you want it on the lateral aspect. And because I chose it here for the AP, I like to be consistent. It makes for that pretty aesthetic image. We're going to have it in this corner when we actually position her for the lateral. We're going to have her turn onto the affected side. And for the camera's sake, I'm going to have her bring her leg up and over She's quite flexible. Most patients won't do this. This is what you might have for a patient, or some patients might even be more comfortable with the leg back rested like this. You'll have to evaluate that in the field. For teaching purposes, though, we've discussed for camera angle that this would be the best. That would be okay like that, Kristen. You're going to have to readjust your shielding, and the next thing I want to do is slide her hips more towards me to get that femur more straight down the table, and she can get comfortable now. Are you okay? Okay. The femur is straight down the table, and we have the lower leg at a 20 to 30 degree flexion. You don't want the leg straight, in other words. It's a slight 20 to 30 degree flexion. That allows the muscles to relax and the bones will go into a more natural position. If you suspect a patellar fracture, do not flex that leg more than 10 degrees. Because if you do, if there is a fracture there and you flex that knee, see the tension and the torque on the patella, you could actually possibly separate the fracture of the patella. Okay? Don't take the chance of putting pressure on that patella with excessive flexion to pull the fragments apart. So 20 to 30 degree flexion, there you go. Okay, now laterals, we do angle the tube routinely for all patients, 5 to 7 degrees. So I have a cephalic tube angle, 5 to 7 degrees. I'm going to adjust the gauge to maintain the 40 inches. I brought the gauge down to say 39, but it's actually a 40 SID. I'm going to want to float the table. Okay, the table won't float anymore, so I need to have you scoot back just a little bit. There you go. I want the crosshair coming down the center of the femur. See how I've come it down the center of the femur. Now I'm going to want you to watch this, what I'm going to do real close. I don't use the apex of the patella for a lateral centering mark because feel on yourself, feel your patella with the legs straight, not muscles tight, muscles relaxed. Now flex your leg slightly, keeping your muscles relaxed, and feel what your patella does. When the leg goes into a flexion mode, the patella actually floats down and it doesn't maintain that same relationship with the joint space. So I have another trick that we're going to show you to help you get the center of the film to the joint space. We're going to want you to, basically you're going to make a T with the lower leg, and part of the start point is at the cross of the leg, right here, where the leg is bending. Okay, you see that? Now when I make my T, I think I'm going to start with where it bends at the knee, and I'm making my T in relationship to the lower leg. See my T? Again, you're going to make a T, but it's with the lower leg. And then where the T comes together, right here, that's the level of the knee joint. With the tube angle, we enter just a little below, because we're angling cephalic now. We enter just a little inferior to the joint space region, maintaining the femur to the center of that crosshair. And now I need to get her into a lateral position. I've centered the knee joint, but we're going to get her lateral. And what you do is you palpate gently. You're just feeling the edges of the patella, and you want the patella superimposed, the edges one right on top of the other. How you manipulate that is I want you to rotate the patient's hips. Watch how I'm moving the hip and what it does to the leg. Okay? I don't want you reefing or pulling on a patient that's hurt at the knee. The hip will do that. So you rotate that hip until the knee is into a lateral position. Now you can also kind of watch the patient's face, because if they're in a true lateral position, they're actually resting right on this lower trochanter and it's uncomfortable. So Kristen knows what I'm talking about, because I have her in a true lateral position now, and she's resting right in that trochanter. And when you practice this in the lab, you'll understand why we say it's not comfortable to be in this position. So watch your patients. You can ask them if they're resting right on that hip, and most of the time they'll let you know they are, or they'll look at you funny because it's not hurting. Okay, so let's just kind of review for a second. This crosshair comes down the leg straight. This crosshair will come at the level of the T. You get the crease of the leg, making a T with the lower leg, and then you're entering just a little bit inferior because of the cephalic tube angle. You need to exit to the center of your film. And I'm going to put my right marker back in the same spot that I had it on my AP. So the end product is very aesthetic in nature, and then the patella is superimposed. The radiograph will give you evidence. It'll show you the knee joint to the center of the film. It will show the patella as being away from the femoral condyles. Away from the femoral condyles. Okay. Now, I want to re-emphasize that the T trick is with the tibia and fibula. It's not with the femur, and many students they understand the T trick, but they forget which bone it's meant to be with. If you make a T with the femur, I'll let this light go off. If you're making a T with the femur and where the cross point is, see, you're actually going to be up on the femur, not into the joint space. You can actually see the joint space right there. Okay. We're going to pause for just a second now and get something else set up for you. We'll be back in just a minute. We've added a little prop to our setup here. If you take a look at the table, we have a skeleton part here to help demonstrate a knee in a true lateral position. The skeleton, you're not going to see the patella away from the femoral condyles just because of the way it's constructed. So you are going to have to do a little bit of imagining. But again, remember, we rolled the patient back and forth until we got the patella perpendicular. The two edges were one right on top of the other. If we did that well, the patella will be demonstrated away from the femoral condyles. But this can be tricky. You will tend to repeat lateral knees. If the patient is over-rotated, see how that leg is getting closer to the table? This is what's going to happen. See what the skeleton has done? It has opened the space between the fibula and the tibia. In a normal position, the head of the fibula is slightly superimposed or overlapped into the tibia. But more that patient is towards the table, more that space opens up there. Okay? The other thing that I want you to remember is the adductor tubercle. It's on the medial condyle. It's a bump right here. And when we look at an X-ray image, if the leg is too lateral, the adductor tubercle, which will help you identify the medial condyle, will be in an anterior relationship to the femur. If you see too much space between the fib and the tib, and you see the adductor tubercle lying anterior, you know that you have taken this X-ray with the knee too close to the table. And to fix that positioning, you need to change your perception and elevate the knee away from the table more. And on the opposite side, if the knee is too far away from the table, like that, look what's happening to the space between the fib and the tib. The actual space is closed. Most of the fibular head is right underneath the tibia. And what will happen to the adductor tubercle? It will be on the posterior relationship of the leg, because the lateral condyle is going to be anterior, and this adductor tubercle, which will let you know the medial condyle is too posterior. You shot that image with the knee too far away from the table, and to fix the scenario, you need to bring the patient closer to the table. Hopefully this setup, this imagination here, will help you get this concept set into your brain. Now that we finished the lesson of the AP and the lateral knee, a lot of departments only do a routine AP and lateral of the knee, but we're going to continue with this segment and demonstrate a patella. So I am again going to let the camera pause while we reset the room up, and we'll be back. We've got Kristen set up for a right projection of her patella. There's many multiple ways that you can demonstrate the patella. First of all, we've ruled out a fracture before we've had the patient bend the knee to this extent. I'm going to show you where we put the lead strip, and then if it falls down, for camera's sake, I won't worry about it, but I've protected her reproductive organs. Okay. And now what we've got going here is we have the patient's leg bent. The degree that the patient can bend their leg, of course, will depend on their pain tolerance. You don't need a lot of bending of the knee, but again, the patient will basically, they'll set themselves up in a comfortable mode, and then you move your equipment to their needs. I've got her set up on the low end of the table because many times it's a difficult time getting the tube low enough. So make sure your patient starts at an end of the table so your tube has flexibility to go lower and clear the tabletop. Okay, we're going to focus on the angle of the patella right now and this shadow of the crosshair. Okay, she just moved on me a second. There we go. We had it perfect a second ago, so we'll just have to kind of set this back up. I'm going to outline the patella here for you. Here's the base, there's the apex, and you can see that the patella is at, probably about a 15-degree angle. Then I've angled my tube cephalic to where it matches that same degree, and I'm looking right at this crosshair here. See the black shadow? It's being parallel to the joint space. That's what you look at to change the tube angle. Now if she bends her knee more, see how my fingers are almost parallel and the tube is angling more, you have to change that. Or if the knee, the flexion changes, your tube angle changes. So you have to get a vision of the joint space and angle your tube to come in right through that joint space. Okay? Now we're going to focus on the film. It is technically more accurate to have the film match the angle of the tube. Then everything, it's either perpendicular or it's parallel to something. The disadvantage of doing this is the fact that you have OID. But technically it's more accurate, and remember when we're teaching you, we're trying to teach you at a higher level because we know that in the field, if we teach you here, you perform here. Every human does. If we were to teach you at this level, you're going to be performing here. That's just human nature. So we set the bar high. We want our standards high for you. So we are going with more of the textbook classic scenario to deal with here. Again, you analyze the angle of the patella and you adjust your tube to be at the same, coming through that joint space at the same angle. And you make the cassette at the same angle as the tube. Okay. You have OID, and in theory, you can have an increase of SID. It's hard to show you this now, but I have about 44 inches of SID here because I'm wanting to compensate for the OID. You know, OID causes magnification, and increasing the SID can help minimize that. Now we're going to focus on the cassette, and I want the crosshair here exiting to the center of the cassette here and here. So the box, the tightly collimated area, goes right to the center of the cassette. In other words, we don't want this. We want you coloring inside the lines. This would be a crooked picture. You would be off balance. This would be a within the line drawing there. And I'll move this marker for now, but I want you to look at the double crosshair here. This is where the central ray is coming. And we want it coming through the knee joint space. There's a dip here that you can use on many patients to indicate that you're coming right down through the patellofemoral joint space. Okay. And that's what you shoot for. I'll set up something that we don't want you shooting for. We don't want to see this, in other words. See how you're not coming down through the joint space? Your central ray is here. It's skimming the body. The joint space is down in a ways. So this is what you shoot for. Exiting to the center of the cassette. And then I'm going to put my right marker. This is a sunrise. The patella is the sun over the mountain, and you can consider your marker the moon, and you want to be able to read that marker. Okay? So think about the sun over the mountain. This is the mountain, and that's the moon where you can read it. If the patient's having difficulty holding this exam, and holding the cassette, and they will, and the cassette moves on you, you might end up with motion. So using a sponge like this can be very beneficial for stability reasons. Again, I have more than 40 inches SID compensating for that OID. You will see some techs just positioning like this. They'll do everything else that we talked about, but they'll have the cassette resting on the leg itself. There will be a little bit of elongation here, but it does produce a very diagnostic x-ray. This is everything is perpendicular. The disadvantage is the OID, but you can compensate for that with increased SID. This is one way to do the patella. We will be back once we're set up for a second option to doing the patella. And we're back with another alternate way to take the patella. Again, there's multiple ways that you can do this, but in the end result, it's the same approach. Let's look at her knee now. The knee will bend to different degrees depending on the patient. You analyze the position of the patella, and you have your ray coming through that patella at the very same angle as the patella. See this black line? It's parallel to that. I actually had to switch to a left leg so you could see it better from the camera. So this is now a left leg setup, but she's in a prone position, and we want to think about the sun over the mountain, and your marker is the moon. And so I'm looking at the sun and the moon, and that's how I have the left marker. It's to a lateral side, but that's how I read it. You know, we don't want it like this. Your moon would be upside down. Okay? So, left marker. And you're exiting to the same level. See how I'm into the depth of the patella, coming right into the joint space there. And I want to exit to the center of the cassette, here and here. Tight collimation, leg straight, and the tube at 40 inches. And that would be another alternative to the patella. When you're evaluating this radiograph, you want to have the patellofemoral joint space open.